Okay, welcome back. And as we're waiting for the last few people to join in, I see that that some of you folks are letting me know where you're from, and actually, I really appreciate that. So we have Stuart listening in from Richmond, California, which I have not heard of, Richmond in California. So maybe Stuart can let us know where that is in relation to a larger a larger city, so that we kind of know. So let me know in the chat box where you're from, your profession, and if you're using BioFlex laser therapy, or if you're using laser therapy, or you're just kind of interested in the potential for laser therapy for different conditions. So, oh, this is pretty cool. We're getting folks from Portugal and Boston, Massachusetts, acupuncturist Marcy, from Gravenhurst, massage therapist, which is great. So just again, let me know where you're from, perhaps what kind of healthcare professional you are or not, and let me know. Once again, my name is David. I'm the medical director at BioFlex Laser Therapy. I do 2 types of webinars a month. I usually do a webinar on our consumer devices or personal therapy systems, geared more towards the consumer that's not necessarily a healthcare professional. So the information's tailored to suit that type of individual. And I also do professional webinars, meaning professional for healthcare professionals. Anyone can listen to either of them. But today's webinar is focused more for healthcare professionals with respect to the anatomy, pathophysiology, you know, some of that kind of stuff that you should be familiar with. Although even if you're not a healthcare professional, I think you'll still get a lot out of the presentation. So just so everyone's aware, these webinars are always recorded, then we edit them. And then we send out a follow-up email that has a link to watch it again. And if that fails, you can always go to our website and find customer support. And then you'll see an icon for webinars, personal therapy webinars and professional webinars. And then you can always find them there as well. So that's basically how you can always access these webinars, even if you can't actually listen to them live, that kind of scenario. If you have questions, I really like questions, let me know, type them into the Q&A box as opposed to the chat box. Ask me anytime, I will address those questions at the end, however, just so I can get through my material. And also you're free to ask me questions at the end of the webinar as well. So today's webinar, as I mentioned earlier, is on plantar fasciitis, which is a really nasty condition if you've ever had it. I've had it. I've had actually most problems that I actually train about. Plantar fasciitis in particular is a nasty one because it takes a long time to get better. And it's hard to really make a big difference in the healing of the tissue. And I'll explain why as we go along too. So I'm going to talk a little bit about the anatomy, just as a refresher. And then we'll get into the epidemiology, pathophysiology, etiology, signs and symptoms. I've tried to update this information as best I can by looking at current research and current thoughts on this type of condition. So hopefully you may find some new information today, even though you may have obviously studied about plantar fasciitis in the past. Then I'll talk a little bit about why laser therapy, or really, it's now known as photobiomodulation, although I typically say laser therapy because number one, it's easier, and number two, most people, that's what they use. Then I'll bring up a couple of research papers. There's quite a bit of research on this topic. Maybe 12 to 15, maybe more papers. I just chose a few, but there is quite a bit. And then I'll talk about how to use the BioFlex equipment specifically for this condition, and then we'll get into any Q&A that you might have. So of course, we know the plantar fascia is on the bottom of your foot. It's a thick band of plantar fascia, obviously in the plantar aspect of connective tissue, and it spans from the posterior tuberosity of the calcaneus, more on the medial side, to the bases of the proximal phalanges. Now, the plantar fascia originates, as I mentioned, from the medial tubercle of the calcaneus and inserts into 3 sort of generalized locations. that form three bands. One is the medial band, one is the central band, and one is the lateral band. And it's a central band that tends to be the problem in plantar fasciitis. So the medial and lateral band, the medial band obviously inserts into the first hallux, the big toe, and the lateral band actually inserts closer to the base of the fifth metatarsal. So these two bands are not typically involved in plantar fasciitis, which is good to know, because I mean, you don't want to be wasting your treatment and where you apply laser unless it's at the accurate condition, accurate location. Can't speak today. The central band is the thickest and strongest portion of the plantar fascia, and is the most commonly involved in plantar fasciitis. It divides into 5 bundles at the mid-tarsal level, with each band attaching to the plantar plate of one of the proximal phalanges, which in combination with these osseous structures of the arch creates a truss. So if you're an architect, which maybe you are, but highly unlikely, you know what a truss is, which is basically, you've probably heard of it anyhow, in a roof or a building, a truss gives support. It's usually shaped in a triangular fashion to provide support for, in the case of architecture, for a roof, in the case of the foot, for the arch. So the fascia is responsible for raising and stabilizing the arch during gait or walking via tensioning. So essentially what happens is when you're pushing off as you walk through with your gait, and then as you push off, your toes are extended. This dorsiflexion of the toes, this occurs in that terminal stance, and at least a tightening of the central band of the plantar fascia, which in turn pulls the metatarsal heads closer to the calcaneus, increasing the height of the arch. So that's part of the role of this plantar fascia. And as you can imagine, if you're weight bearing a lot and doing lots of activities that are involving weight bearing, like running, then this type of condition seems to be more common. The medial longitudinal arch of the foot is sustained again by the plantar fascia, but also by a very specific subcutaneous structure of dense connective tissue surrounding it, including the Achilles tendon and a series of ligaments. So there's lots of different tissues that provide support to the arch, not just the plantar fascia. If you look microscopically, and this is really critical to understand the pathophysiology and why this condition is so tremendously difficult to heal, is that it's composed of dense, well-organized collagen strands in nice parallel alignment when healthy. But most of us, as we age or we have plantar fasciitis or fasciosis, as it really should be called, this starts to actually degrade. So this condition is quite a common cause of foot pain, mostly in adults. And it's characterized obviously by pain. And we all know that usually when you ask your patient, it's when they first place weight bearing or walk in the morning or after a long period of rest, like maybe watching a movie or sitting on the sofa or a chair, what have you. It's usually located at the plantar fascia insertion, but and it can also be bilateral, but usually it's unilateral. It affects both sexes, obviously, and it can be in elite athletes, recreation athletes. They do find that women are affected slightly more often than men. These stats are always hard to figure that out. And in part, it might be just because it's reported more, because women tend to take care of their health smartly more so than men, who are not so smart often. Despite this diagnosis of itis, plantar fasciitis, is actually not the correct term to use, because really it's characterized by an absence of inflammatory cells, especially as the condition progresses. There may be some acute inflammation if there is a traumatic event or some tissue that tears, that kind of thing. But typically this is a degradation of the tenocytes or fibrocytes within the fascia itself, and that's what leads to the condition. So it's really, this degenerative pathology is similar to something that you might consider like a tendinosis. So really it should be called a fasciosis. I saw that term in a couple of research papers. So it's typically an overuse injury, and it's primarily due to repetitive stress or strain, which leads to micro tears, obviously, of the plantar fascia. So an increased fascial load is sensed by what's referred to as the gap junctions between fibrocytes. This is getting a little technical now, but fibrocytes are tenocytes in tendons. These are the cells that produce collagen and help it to mature and keep the health of a fascia and tendon-like material. So what happens is you get something called mechanotransduction, which mediates changes in the extracellular matrix when there's excessive load. And so basically the cells start to release different enzymes, including MMPs, which are metallomatrix proteinases, and others, which you may or may not know of. And this actually causes degeneration. And it results in something called myxoid degeneration and fragmentation of the plantar fascia and perifascial structures. Basically, it turns it to goo as opposed to nice, strong, healthy collagen fibers. So that's the problem. And you need to reverse this, and it's not easy. So this is what normal healthy collagen would look like in a normal healthy plantar fascia. On the right is when you get this degradation of an increased mucoid. So the mucoid you can see are these gaps, they're sort of the white spaces, and you can see the cells. The collagen is not in nice parallel fashions, it's actually disorganized, more like a spider web. And so this tissue doesn't provide as much support, and it easily gets irritated and degenerates. And this is the source of plantar fasciitis or fasciosis, as I mentioned earlier. It's not uncommon that people often mention, well, do I have a spur? And in fact, approximately 50% of patients with plantar fasciitis may also have heel spurs, but typically the heel spur is not what's causing the problem. Oftentimes what happens is you get an x-ray, the x-ray shows a spur, and they go, oh, the problem's a spur. But it's, unless it's pinching or really quite large and causing inflammation in that area, it's usually innocuous and not causing a problem. So it's more along the lines of excessive mechanical stress has caused that spur to form, but the problem is the actual fascia degradation. So pain can be located in the mid-medial arch, in the mid-calcaneus, and the fascial origin. You can see potential locations. We probably know that it's the medial calcaneotubercle, the red dot, where it seems to be, you touch that in these patients and they scream at you. That's usually where the epicenter is, but oftentimes you'll find pain in these other locations as well. But notice it's not usually in that lateral band or that medial band. So when you do laser therapy, you want to focus it in these locations, especially where there tends to be pain. There can be an acute phase of plantar fasciitis, and it oftentimes turns into chronic issues, and is characterized by remissions. So basically, person rests, they're feeling pretty good. Oh, I'm cured. Then they start running again, and it's back. And that's the problem with plantar fasciitis, is that it's not properly healed, and that's when it starts to continue to recur because it is a degenerative process. With respect to this condition in runners, it averages anywhere from about 5 to 10%, and it is the third most common injury right after shin splints and Achilles tendinopathies. But if you're an ultra marathoner, God knows why you do that, but all the power to you. If you do that, then you have a greater incidence of plantar fasciitis reaching up to 11% or so. So there are risk factors. So there are anatomical risk factors. If you have mechanical issues like pes planus, pes cavus, overpronation, leg length discrepancy, torsion issues, if you're overweight, these can all potentially contribute to the development of plantar fasciitis. So what you want to do is prevent it. So address these mechanical issues if you see them on a patient, even if they're feeling good. And oftentimes patients would question as to why do I need orthotics or whatever. And it's like, okay, you're an overpronator. And they say, well, I don't have any problems. It's like, okay, well, you may have arteriosclerosis in your coronary arteries and you don't know that. Would you not want to slow that process down to prevent a heart attack? Yes, I would want to do that. So why wouldn't you want to take precautions to reduce excessive mechanical stress on tissues that will lead to problems later in life, that then become even more problematic to get better. There's issues with functional risk, like gastrocnemius, especially tightness. So it's one of the stretches that we highly recommend. And soleus to some degree, but the gastroc is more critical, as well as the Achilles being an issue. And sometimes there's strength issues, so you can also do strengthening exercises. And there could be degenerative issues as you get older. The fat pad degenerates on the heel, that kind of scenario. So just in general, as you age, things go to crap, right? So, so you need to be aware of that. Extrinsically, there can be overuse, so people just, as I mentioned, like ultra marathoners, that kind of thing. Incorrect training is also really common, especially for people that aren't working with professionals or trainers, and they just go out and do stuff, and they realize that all of a sudden they're going too quick, too far, up and down hills, too much loading, and you need to do those things gradually, and that's why it's important to work with trainers, or at least certainly research as to how to approach doing that kind of training. And of course, inadequate footwear, that's definitely an issue. It really pays to get good footwear that's supportive, and maybe wearing an orthotic if there's mechanical issues there as well. There's a few differential diagnoses that one should be aware of, peripheral neuropathy. There can be L5S1 issues that can cause pain in that general location, tarsal tunnel syndrome. There can be traumatic, although the person's usually aware of that, a fascial tear, they've fallen from a distance, that kind of thing. And certain arthritic conditions, arthritides can lead to issues in that area. And as I mentioned earlier, degenerative conditions like fat pad atrophy, or of course, degenerative condition of plantar fasciosis would be your diagnosis. So I don't know why they put that into the differential diagnosis. Well, I guess for heel pain, that's why. Okay. So usually this is self-limiting, which is great, but it takes a long time. So about 90% of people will feel significantly better if they just leave it alone, don't do anything with it, and try and let it heal up. And with conservative treatment, you're looking at 3 to 6 months, but it may even be 9 months to a year. So, your goal is to get this time down so that the patients can start doing their activities. Initial treatment, they throw NSAIDs. I'll talk about that in a second. Stretching isn't critical. Orthotics are really important supports, and potentially night splints. Although if you've ever worn a night splint, it's not the most comfortable thing. And, most people don't just get rid of it because they can't sleep with it on. The last webinar, I mentioned about a recent McGill study, and they actually found that patients that are taking NSAIDs or anti-inflammatories like Advil, Aleve, these kinds of medications actually lead to a much higher incidence of chronic inflammation, which is what you're trying to avoid. So it's not a smart move to actually take NSAIDs for a tendinosis condition. To be honest, for any condition, because only temporary relief, it blocks the pathway of inflammation, and by blocking it doesn't let the body resolve it, and hence chronic inflammation. So really, the study showed that we should start thinking about, although they did say, well, you should think about other pain medications, which is like, come on now. There's other things that you can do, not taking pain medications. So try and avoid NSAIDs for plantar fasciitis, especially for any other conditions as well, because it oftentimes will lead to chronic problems. Orthotics, they decrease the heel rise and Achilles tendon force during gait. And this helps with pain. So it is quite important to have these. You can use over-the-counter or prescription. I actually read somewhere that said over-the-counter were more effective than prescription. I don't know where they got that information from personally, but you can try both. I've had patients that have had success with over-the-counter devices, but most seem to find that they don't help. And that's where if you get them scanned or casted, I do the old-fashioned plaster cast. I find that quite effective as to restoring the arch the way it should be, and then making the orthotics from there. Night splints, this is what they look like, quite bulky. And the idea there is it prevents plantar fascial contracture by maintaining a neutral position of the ankle during sleep. It is most effective in patients whose chief complaint is waking up in the morning with morning pain, but you got to deal with that on your foot. So that might be a bit of an issue because poor compliance oftentimes leads to patients not using it properly. Although a recent Cochrane review concluded that night splints in conjunction with custom foot orthotics produce significant pain relief. So there's that. Stretching of the gastrocs, make sure your knee is extended. Is really important. This is can be self-directed or guided by physical therapist, chiropractor, or whoever is taking care of you, or your patient, I should say. And again, the knee should be extended because that way you're getting the gastrocs as opposed to the soleus if your knee is flexed. Stretching the plantar fascia itself, you can see a nice little exercise here. Essentially, the foot to be stretched is placed on the contralateral knee, ankle is maximally dorsiflexed, and the toes are pulled up, tensioning the plantar fascia itself. And you can also sort of massage the fascia as well. So that's a good little stretch as well. Shockwave, lots of people rave about shockwave for plantar fasciitis. I'm going to go head to head of laser therapy and shockwave, so don't be shocked if with the results. Pun intended. So shockwave, actually, it is, you know what, if I had a shockwave, I would use it along with laser therapy. If I were to choose between the one or the two, I could only buy a shockwave, only buy laser therapy. I'm going to buy laser therapy, even though, yes, I work for BioFlex laser therapy. I'll tell you why, is that you can use laser therapy on almost every condition and many off-label conditions for your patients. Shockwave is very limited. Right. So I'd rather go with a tool I can use for almost everything and then add the second tool when I've made money off my first tool kind of scenario. So shockwave actually does show pretty good efficacy. So it's not bad actually to use. Corticosteroid injections, please don't recommend those. Try and dissuade your patients from having those. Because we know that this is not an inflammatory condition. So it really, in fact, it's just going to make it potentially weaker, the tissue, and make it more prone to rupture. Last thing you want to do is cause that scenario, just like in Achilles tendonitis. Don't have them get steroid injections because, again, that's going to weaken the structure and potentially cause more problems, including rupture, and then you're in a whole lot of pain with that. PRP, I love PRP, but there's not a lot of great research on it yet for plantar fasciitis. There's some that shows it's effective, but not enough yet to highly recommend it. PRP basically is autologous whole blood. You can see its blood is drawn out of your body. You spin it down, you transfer it, then you spin it again at a different centrifuge rate. You separate the platelet pellets, and then you're left with homogeneous PRP or platelets to be able to re-inject into your patient in specific areas. And it's thought that they produce growth factors that help activate intrinsic cellular mechanisms. And this, of course, might help plantar fasciitis. So why would you choose photobiomodulation therapy or laser therapy? Well, there's an inordinate amount of research that suggests that it can help improve collagen fiber organization. It can increase synthesis of type 1 collagen due to tenocyte, or actually not so much tenocyte, but in the case of fascia, fibrocyte proliferation. It downregulates the enzyme that degrades the extracellular matrix, including MMP. Reduces inflammation. Again, remember, this is not so much an inflammatory condition, but you can get bouts of inflammation, especially if it's acute. Let's say the tissue is healing, it feels pretty good, and then you go and do something and it flares up. There might be a bit of acute inflammation there, so it's going to be helpful for that. It upregulates insulin growth-like factor, which increases cell proliferation and matrix remodeling, reduces fibrosis, and temporarily increases ROS, which are reactive oxygen species molecules. And these are important cell signaling molecules that help regulate cell cycles in order to allow them to increase their activity, metabolism, and mitotic index, and lots of other things. So research-wise, this particular paper looked at MRI imaging and outcomes of laser therapy, ultrasound therapy, extracorporeal shockwave therapy for plantar fasciitis. Looked at 60 patients with chronic plantar fasciitis. They're randomly divided into three groups. They either received laser therapy or continuous ultrasound or shockwave. They were all assessed using a VAS and heel tenderness index scale, American Orthopedic Foot and Ankle Society, ankle hindfoot scale, Rolls Maudsley score, God knows what that is, and an MRI before and 1 month after treatment. So success rate was 70.6% in the laser treated group, 65% in the shockwave. So pretty similar, but guess what? Laser therapy was a little bit better, and 23.5% in the ultrasound group. If you do those two together, ultrasound and shockwave, I would bet you $1 million that you would see a much higher percentage of success rate. This one looked at the parameters and effects of photobiomodulation in plantar fasciitis. It was a meta-analysis and systematic review, which tend to be a little bit more powerful. They looked at, they searched out and found 3,865 studies. However, of course, they whittled that down to 7 randomized controlled studies were selected for final review and 4 were done for meta-analysis. And overall, the effect of photobiomodulation was statistically significant, favoring for thickness of plantar fascia reduction, meaning that you're getting the tissue healing. What you want to do is if you have imaging, MRI or ultrasound, it's thick. You want to have the imaging as the person's progressing and show that it's thinning, meaning that it's healing. Because the thick fascia means that there's lots of mucoid degeneration and this kind of, jello-like structure in there that you don't want. So they concluded that photobiomodulation is an effective treatment modality to reduce pain and improvement of foot function in patients with chronic plantar fasciitis. But as usual, there's a broad discrepancy found in the dosimetry of photobiomodulation. No surprise there, because we know that different ranges of dosimetry or dosaging can actually work as long as you're in that window of range. So if you're too low or too high, then you're not going to see the results. But there is a range, and that's what they're referring to there. As far as how you're going to use our equipment to treat plantar fasciitis, I really like doing it this way. You roll up a towel to induce the medial arch, and then you place the array, whether it's a dual 180 or dual 240 or whatever array that you have, and then you put it on top of the towel. Then you have the patient gently put their foot on top of this. The arch is created, and you get good contact of the diodes directly with the skin surface. Those of you who are new to laser therapy or maybe don't know about BioFlex laser therapy, our diodes stick out from the device. Most competitors, actually probably all competitors, their diodes, if they're using LEDs, are recessed behind a glass plate or behind recessed holes. And the problem with that is they don't make good contact with the skin, and they don't depress the skin, allowing more light to penetrate. So they get more reflection. The way ours are designed is to maximize the absorption of light by literally poking the LED into the tissue, not so it's, causing a laceration, but just so it gently pushes into the skin, and that skin folds around the diode and allows light to go a little bit deeper. Second placement is an array that's going to cover the posterior calcaneus and even up around the Achilles tendon region and the insertion as well. So those are the two kind of standard placements that we would use. The protocol that we have, again, if you're new to BioFlex and you're not quite familiar, we've developed proprietary dosimetry protocols for many different conditions and anatomical regions. These are based on 30 years of using the equipment in our own BioFlex outpatient clinic that was started by Dr. Fred Kahn, who was the founder of BioFlex. He passed away last year, and he did this, for 30 years. And, we saw lots of conditions. I've been here about over 11 years now. And so we would chart and track how different conditions respond to different dosaging, different parameters. And over time, we would, with the team and Dr. Kahn, we would sort out what these parameters would be most effective for different conditions based on our results. And then we would come up with these protocols. So if you look at the protocol, the stage 1, which is the beginning stage, there's a range of pulse rate of 10 to 20, pretty low for infrared. and a duty cycle of 30%, which means it's 30% of the output power, all the way up to 90%, which is 90% of the output power. Red light is used first, always continuous wave. The idea there is it's saturating the photoreceptors in the very superficial aspect of the tissue, allowing for the infrared that goes on second to go deeper into the tissue, in this case, the fascia, which tends to be quite thick. And normally red light's not going to penetrate very well into that, but infrared will. And then using a laser diode class 3 probe, in this case, continuous wave, but we tend to set it around 40–50% power. Maybe a total of 6 minutes, but we're going to choose different points. I'll talk about that. And then you can see we can slowly progress to more stimulation and more pulse rate, for example, as you go from stage 2 to stage 3. So you want to, as far as the laser probe goes, you want to apply the probe to the areas where there's pain and tenderness. That usually on the medial tubercle, could be on typically the central portion of the tendon of the fascia, itself. So make sure you treat all along through there. Hold the laser for at least 5 to 10 seconds. You may have to hold it longer. Remember, this is variable because it depends on how thick the foot is, how thick the fat pad is. So you have to use a bit of laser common sense here to understand that if you have a thick foot, then you need to hold it longer. If you have a thin foot, and usually you see that in elderly patients or patients in their 50s and 60s and beyond, because that's when you start to see more degeneration of the fat pad. Once you finish one point and do all of them, you can go back and treat those points again another time or two if you wish. Remember that when you use a laser probe, it needs to make good contact with the tissue. In fact, you should also gently push it into the tissue to allow it to displace blood and to get it closer to your target tissue. If you hold it at an angle, you will lose some light energy because it will reflect off the skin. So make sure it's held at a 90 degree angle. So again, you're going to be holding the probe, this is a repeat, at least 5 to 10 seconds. And don't forget to treat myofascial trigger points and other tender spots in and around the ankle-foot complex. If you have a red laser probe, it's very helpful for an analgesic effect because it basically doses the sensory receptors on the surface of the skin quite nicely, and it can help with pain. So if you don't have a red laser probe, I do actually highly recommend that you add that to your regime because it does help with pain a lot. If there's callus buildup of the foot, you may have to hold the black sensor tip of the laser probe with your finger to engage the power because it doesn't make good contact if the skin's super dry. Okay, I just repeated all that. So treat initially 3-4 days in a row, especially if the patient's coming in pretty sore, and then 3 times a day, eventually working your way to every other day until there's pretty significant improvement. It may take a few weeks. I mean, it may take longer. It's hard to say, but these patients are notoriously difficult to get better. And eventually you can get down to once a week. Treatment plan realistically on the low side, 10 to 12 sessions. On the high side, and getting up there is 24. So you're looking at around a couple months of treatment over 2-3 months or what have you. That is realistic. But if you can get a plantar fasciitis that just started, significantly healed in 2 or 3 months, that is a really good effect. Don't forget to underaddress underlying causes. I've mentioned earlier. If you're going to use shockwave, do it before laser therapy, then do your laser therapy. So that's the treatment plan I would lay out, along with exercises and all the things I mentioned earlier. Our upcoming events, we have some different webinars coming up. One is why light therapy is better than Advil, Aleve, and Motrin. This is more for personal therapy system users, but anyone can watch that. And this kind of relates to that McGill study. Laser therapy for treating muscle strains, that's more of a professional webinar. And then how does it compare to LED panels and other devices, meaning our BioFlex personal therapy devices, because many of you do ask those questions. And then why many massage therapists are seeing the light and incorporating laser therapy into their practice. That one's geared obviously more for massage therapists, professional massage therapists wanting to learn a little bit more about how laser therapy can be incorporated into specifically their type of manual therapy. Okay, let's see if you have a few questions here. I think you do. Okay, so how about the pad of the foot near the toes? Well, that's not affected in plantar fasciitis. Typically, I know that there is a pad there. That oftentimes results in metatarsal head issues, metatarsalgia, that kind of scenario. So there may be concurrent stuff going on there as well too, but not specifically for plantar fasciitis. Oh, thanks for joining us, Karen. Karen's an acupuncturist, which, by the way, I noticed that quite a few, well, some of you out there are acupuncturists. If you're an acupuncturist or you do acupuncture as well in your practice, can you email me, please, david@bioflexlaser.com. I want to set up, and I want to do a little bit more training for acupuncturists specifically, and I want to get some feedback on using our devices for laser acupuncture. I am an acupuncturist myself, but to be honest, I don't do acupuncture anymore. And so I do want to find out a little bit more clinical anecdotes and clinical pearls from those of you out there that do laser acupuncture. So please reach out to me at david@bioflexlaser.com. I will make sure it's worth your time. Perhaps I'll throw in a free training or advanced certification training course if you reach out and you can help me out. Could we get a link to this study about inflammation and medication? Wendy, if you Google McGill and NSAIDs, research study, just using those key points, you will see that you'll pull up that study. If you want an actual copy of the study, email me and I'll try and get it. So with respect to using a personal therapy system device for plantar fasciitis, same placements, by the way, and use the foot and ankle protocol that comes with your system. If you're using BioFlex in combination with IMRS, PEMF therapy, which should be conducted first? I'm not sure I really understand the mechanism of action of PEMF. But in general, I would say do laser therapy after any other type of therapy, to be honest, because it's working on the cells and it's having an impact on their cellular metabolism. So whatever you're doing before, whether it's increasing circulation or whatever it is, I think that it makes sense to do laser therapy afterwards too. But to be honest, I don't have a lot of experience with PEMF. Actually, I kind of like PEMF. I just don't use it a lot. As far as icing, rolling on ice bottle, that kind of thing, it can provide temporary analgesia for sure. Remember, this is not an inflammatory condition usually, so I wouldn't do that unless there's definitely some inflammation going on, or just to kind of calm it down a bit as far as making it feel a little bit better. But I don't think it's really going to do a lot for the pathophysiology of it. As far as a subtalar joint involvement, I mean, yeah, there's like when you look at the mechanics of the foot as a chiropractor, I'm going to be adjusting those different joints, absolutely, for sure. And when I was reading about plantar fasciitis, they didn't get a lot into the joint involvement, but as a chiropractor, I know that that's a big part of the issue, is that you're going to get mechanical issues in part causing problems or resulting problems for joints. So I would definitely deal with that as well. I'm not sure if I answered that question, but I think it is involved. Or were you just using the protocol for foot and ankle and plantar fasciitis? Oh, sorry. We actually have a plantar fasciitis protocol. So that protocol I showed you earlier is specific for plantar fasciitis. If you don't have that protocol or not quite sure of it, you'll find in the recording of this, or you can email me and I'll get that out to you as well. We have lots of extra protocols that may not be in your system for professional systems. We have a clinical manual done by Dr. Khan that had every one of his protocols in there, even if they're not embedded in the software, and we can get that to you through our clinic. So a patient here has pain near the aponeurosis origin, reports is worse after walking. She walks treadmill. So here's the thing with plantar fasciitis. It feels better when you first start to do activity, and then it starts to feel worse again as you're doing the activity. That's very typical of plantar fasciitis. So usually they go, oh, it feels better when I start doing stuff. Then they go, oh man, how come it's bothering me now? That's usually how it goes. I don't know if that answered your question, Evelyn, but that's kind of how I took it. Which probe for the subtalar joint? I would use the infrared probe for the subtalar joint. Okay, that's it. Thanks a lot for joining me. Maybe you can join me for the next series of webinars, and email me if you do laser acupuncture. I would love to hear from you, and so I can set up some webinars and some training for laser acupuncturists. Thank you so much. Take care and have a great day, everyone.